Well, good afternoon and welcome to the annual public meeting and annual members meeting of Lincolnshire Partnership NHS Foundation Trust. My name is Paul Devlin and I'm the Trust Chair, and I'm going to be steering us through the meeting today. We've titled this year's event Moving On from COVID-19 in recognition of the impact of the pandemic on the last year and indeed its ongoing impact. Today is going to be a chance for us to reflect on some of our achievements, including the fantastic response to the pandemic from our staff and volunteers. The board and I have been absolutely overwhelmed with the incredible professional and patient-focused response to COVID-19 all our staff and volunteers have shown. And that recognition is shared by our Council of Governors too. I also want to acknowledge the impact of COVID-19 on staff and volunteers themselves, not only professionally, but also personally. I know some have lost loved ones, have lost friends, and indeed lost colleagues to COVID-19. My heart goes out to you. The annual public meeting will have a series of pre-recorded presentations, though the questions and answers will be being handled live. So if you could type your questions using the Q&A facility on the live streaming during the presentation, they will be picked up and we will ask and answer as many of those as we can at the end of the presentations. We're also going to have the opportunity to recognise some volunteer long-term service awards, which is a really important part of what we do each year. And we're going to have a live announcement of our governor election results. A little later on, we'll be hearing from a number of our services about some of their great achievements throughout the last year and some of their plans and thinking for the future. Now, we will do our best to stick with the timetable that's up there, but please bear with us, as obviously we are doing this annual meeting by digital means for the first time, and we will be learning as we go, I think. So without further ado, I'll move to our first video on some reflections on the year and our achievements. So, looking over the year, we were re-inspected by the Care Quality Commission, the CQC, just as the COVID pandemic hit. So actually our well-led review was postponed. It was actually due about a week after we went into lockdown. But the CQC was able to assess the trust based on much of the information and data provided, and also on doing a site visit a little earlier in the year. And the trust continues to be rated good overall and outstanding for well led, which I think is a really strong achievement and a great reflection for all of our staff. There's been a lot of new investment in local mental health services, learning disability and autism services. And I'm really pleased to say that we were able to get £7 million of national investment into the Lincolnshire system to transform community mental health services for people with severe mental illness. It's a very welcome additional investment for us. Our community transformation includes investment in a new approach to community mental health services, as well as pilots of new community rehabilitation services and services for people with personality difficulties and complex trauma. That's initially in the Lincoln and Gainsborough areas, but with an ambition to extend across the whole county. As well, we've been able to secure additional support for Lincoln's rough sleeper community, a particular community affected really difficultly by the COVID crisis. And as a trust, we're committed to eradicating dormitory accommodation across our inpatient wards. And we were able to secure and deliver an investment of £4 million to provide individual bedrooms and improve privacy and dignity on our Brant ward. We've also had a welcome boost for our crisis services, which has enabled us to develop a 24/7 mental health helpline and 24/7 mental health liaison in local accident and emergency departments, both of which are services that we have known were well needed across Lincolnshire. The helpline has been particularly invaluable during the pandemic, enabling people to access support and advice over the phone during these unprecedented times. And we've been able to develop our Criminal Justice Liaison and Diversion Service in conjunction with Lincolnshire's Action Trust. This means providing early mental health support and intervention for people as they come to the attention of the criminal justice system. And we've developed a new autism support network. It's funded by Lincolnshire County Council and NHS Lincolnshire clinical commissioning groups. Unfortunately, the groups haven't quite been able to make the impact hoped for, as much of their activity had been planned just as the pandemic hit. But we're hoping to get back up and running very, very soon. Mental health support teams and Healthy Minds will be invaluable in supporting schools and pupils following the pandemic as they restart their term this month. And it's important that we seek to continue that support in our schools. We've piloted a new home treatment model for young people, which has helped prevent hospital admission. And we've expanded our perinatal mental health service, our individual placement and support service, and also our veteran support services. All really, really positive developments for us. We had to temporarily close the Ash Villa unit, our inpatient unit for children and young people. We had some real challenges around our staffing levels and recruitment, but the new home treatment model that we developed is absolutely preventing young people being admitted to the hospital, and I think we've been able to bring a very good result out of a challenging situation. We've brought additional investment to be able to develop our transforming care agenda for people with a learning disability, and also supporting those people with a diagnosis of autism. That's been a welcome development, something that we've been looking at for a number of years. So, as with previous years, our teams have been recognised in many, many ways through various national and local awards, and it's always good to see that the work of our staff being recognised in this way. So just to highlight a few of these. Our Steps to Change service achieved the Royal College of Psychiatry accreditation programme for psychological therapist service, and 6 of our community mental health teams have now achieved the Royal College of Psychiatry accreditation programme for community mental health services. Our inpatient services and crisis teams were awarded Carers Quality Awards from Everyone. Individual Placement and Support Employment Service was awarded the Centre of Excellence status from the Centre for Mental Health. And our community mental health teams achieved the 2nd star from the Triangle of Care, a really important project ensuring that we focus in on the carers of those who use our services. Lindsay Khan, our team manager for our Veterans Service Tills, was shortlisted in the English Veterans Award in 2019 in Role Model of the Year category, and won the British Journal of Nursing Award for Mental Health Nurse of the Year, a fantastic achievement and a really welcome recognition of Lindsay and her work. Laura Forster, our Senior Data Warehouse Developer, was shortlisted in the Excellence in Women's IT Awards in the Rising Star of the Year category, and also in the Unsung Hero Awards 2020 in the IT and Digital category. Healthy Minds Lincolnshire was shortlisted in the Children and Young People Now Awards in the Mental Health and Wellbeing category. Dr. Jazz Full won Care Coordination Association Good Practice Award 2019 in Innovation to Support Service Development. The LPFT Staff Recognition Programme was shortlisted in the Best Employer for Staff Recognition category in the Nursing Times Workforce Awards. And for the 9th year running, Lincolnshire Partnership Trust was ranked in Stonewall's Workplace Equality Index, narrowly missing out on the top 100. So a fantastic year. Those are just some of the awards and recognition that we've seen of our people during the year, and I'm delighted that we've been able to highlight some of these for you. So I do want to say a big thank you. This has been an absolutely unprecedented year for the NHS and for this trust. And I'm so proud of the way that our staff and volunteers and those who use our services too have been able to step up in such difficult, strange and indeed scary times. We would not have been able to do what we've done without that dedicated team of staff and volunteers, without support from our members, from our Council of Governors and indeed my colleagues on the Board of Directors. I'd also like to thank our staff side representatives who have worked tirelessly with us to enable us to transform services. Our local MPs, local government and other health and care stakeholders, and of course our third sector partners. And we usually each year hold a long service awards ceremony. It's an opportunity for us to recognise volunteers who have given long service to the Trust. Now obviously in the current time, given social distancing measures and the caution around COVID, we've had to do this in a different way. I'm delighted to say that we did have a long service awards ceremony which we conducted in a very careful way to make sure that we retain social distancing, and we were able to recognise a number of volunteers, all of whom had given 6 years service to the Trust. So I would give a great shout out to Millie Allinson, Desiree and Joseph Applewhite, to Helen Bussey, to Christine Cooper, and to Carol Granger and Lincoln, her dog, who also received an award and a badge. They all have given 6 years service. So 36 years service is fantastic. And it was an absolute delight to meet with them and to hear a little bit about what fantastic work they've done as volunteers for us.
Well, it's really good to be able to, it's a real privilege to be able to give those reflections on behalf of the Trust. And we're now going to move into the formal part of our annual public meeting. The first thing that we need to do, and again it's a little strange doing it digitally, is just to review the minutes from the last annual public meeting and to invite any comments in relation to those minutes before we approve those. So there is a link, I believe, in the Q&A linkage for people to have had a look at those minutes. I'll just pause for a moment just so that people have had a chance to look and to invite any comments if there are any. I know it always feels like a long time ago since we were last together when we look at these. I'll just pause for a moment to see if there's anything coming through. Okay, I'm not seeing any indications there, so we will take those as approved from last year. So it now gives me a delight to introduce to you the first of 3 inputs from executive directors. I should say just to preface this first one, that usually the chief executive of the Trust gives the overview of the Trust's performance during the year. This year, unfortunately, Brendan Hayes, our chief executive, is not well. So Brendan, we wish you the very best, and in Brendan's place, Jane Marshall has recorded the video and will be able to take questions after hearing from colleagues too. So let's move to the video from Jane.
Good afternoon, everybody, and welcome to Lincolnshire Partnerships Annual Public Meeting. My name is Jane Marshall. I'm the Director of Strategy, Planning and Partnerships for the Trust, and I'm here representing Brendan Hayes, our Chief Executive, who can't be with us today, to give an overview of the last year and our strategy going forward as an organisation. I'd like to start by talking about our geographical spread and the number of sites we have. Obviously, as an organisation, we specialise in mental health, learning disability and autism services. and we serve 756,000 people in Lincolnshire. In addition to that, we are lucky enough to provide services into North East Lincolnshire as well, where we provide children's and young people's mental health services. And there is a population in North East Lincolnshire of 160,000 people that we serve. We do that across a huge geography. When you look at the profile of our population, we have 55% of the people we serve are adults, 23% of the population are aged over 65 years, and 22% of our population are young people. And we currently operate across 50 bases throughout that geography. So a lot of different community bases that we provide our services from. In terms of our service users, what we know is that we have approximately 50,000 people who are receiving services from us at any one time, and that there are currently 360,000 appointments per year, roughly, that we provide as we go about delivering those services. So that's a little bit about us and what we do. If I can move on to some of the things we've been paying attention to over the past year, we have had an improvement journey that we've taken in terms of the quality of services that we provide. And my colleague Anita Lewin, who's our Director of Nursing, Allied Health Professionals and Quality, is going to say a little bit more about the detail of that. But if you look at very high level about the journey we've been on since April 2016 to the current day, we can demonstrate through our regulators that we have worked hard with their support to improve our ratings against the Care Quality Commission's assessment, and we've moved to a really good position, being rated good overall for our services, which is great. So we are caring, effective, responsive, safe, and we're rated good for those, with an outstanding rating for our well-led element that were assessed by the CQC. We're very proud of that, because what that means is that we are able to provide very good services for the people we serve, and we do that across a range of different services provided by our organisation. Those services range from very specialist inpatient services that we do from our wards, through to more primary care facing community services, such as our Steps to Change IAP service and our community mental health teams, that we're increasingly looking at all age services and doing things not relating to any level of age, but doing things consistently, whatever age you are. We were lucky enough to have a Care Quality Commission visit earlier this year, and that confirmed our ratings as good overall, with outstanding for well-led. We were lucky enough to have an assessment of our rehabilitation services, and that resulted in some change to our ratings, but we retained a good for that service overall. And that service particularly is going through a lot of change at the moment, where we're looking at delivering different models and improved models of care. As I said, Anita Lewin, our Director of Nursing, AHPs and Quality, will explain more about that as we go through. So really good results on our assessment of our quality as an organisation. The next area that I'd like to speak about is how we perform as an organisation. And again, it's a really strong position that we're in, and that has been continued strong performance over the last year. We have been able to maintain our score of 1 for the NHS Oversight Framework, which basically is an assessment framework that looks at how organisations use the resources that are available to them, and how effective they are in making sure that we spend money in the right ways to target improvements in patient care and deliver the right services. I'm really pleased that through the good work of all of our organisations, supported by our expert finance team, we remain in segment 1 as an organisation, which is a really great place to be, because it means we do well on our resources and our money. The second area that I'd like to talk around is what patients think about our services. So we're measured according to what's called a friends and family test, where we ask friends and family what would they recommend LPFT services to their friends and family. And we currently have around 90% of our patients saying they would recommend LPFT to their friends and family as a place to come and receive services. We're very proud of that. In addition, we have around 4,000 expressions of thank yous, of satisfaction for our services, and we are making sure that we are not complacent, that we continue that good performance, but we continue to make sure we improve all the time with what we do. So we are continuing to focus on reducing the number of people who have to travel out of Lincolnshire for their care. We call those out of area patients, and there is a national target to eradicate inappropriate out of area patients by next March 2021. You'll hear lots of what we're doing, what our teams are doing to increase our capacity, to reduce the number of adults with acute mental health who have to travel outside of Lincolnshire for their care. Previously, we had around 50 people going out of area, but we're making really good progress. We're now down to around about 20 people out of area. That's still too many, but we have an absolute plan to reduce that number to 0 by the required deadline of the end of March 2021. And what that is a really strong indicator of improving quality for care, because we know that there are all sorts of knock-on impacts which don't make the patient experience good if you're having to travel a long way for your care, including the fact that by definition you're away from your family and friends. People find it more difficult to visit you because you're away, and generally speaking, your recovery takes longer if you have to travel further. So we're working really hard to eradicate the number of times that happens inappropriately for the county of Lincolnshire and the people we serve. The other big area we are focused on, in addition to our core delivery of services, is of course improving care for people who live with a learning disability. And under the Transforming Care policy, which is a national policy about home not hospital for people with learning disabilities where we can, we are working hard with our clinical commissioning group colleagues to make sure we meet the expectations of that policy, and that people who require support, who have a learning disability and autism, are seen as close to home as we possibly can make it. And that if they do receive hospital care, that is absolutely of the best quality we can make it. So we'll continue our focus on the National Transforming Care Agenda, improving the links between mainstream mental health services and our learning disability specialists to ensure that reasonable adjustments are made and people are able to access the most appropriate services for their needs. And the final thing I want to speak about in this section is our commitment to carers. Carers are really important to us, and we know that carers are on the front line every day, but have been particularly important during COVID-19 and the crisis and the pandemic that we've had. So we're ensuring that through the work we're doing to come out of COVID and through our recovery, we are really listening to the voices of carers in terms of what they need, what help they need to get them through the COVID pandemic, but also how we strengthen our partnership with carers, as they are an absolute key part of our workforce and we regard them as such. That without them, we wouldn't be able to do the job that we do. So really important that we continue our commitment to them, and pursue something that we call the triangle of care, which is essentially the partnership between the patient, the carer and our organisation LPFT. So we get that triangle right and we do everything we can to support our carers. We're proud to be a member of the Triangle of Care, which is an accredited scheme, and we currently have 2 stars in the Triangle of Care, which is a really good place to be, because that means the organisation's been assessed according to an accredited framework about the care, the support we are able to give our carers, and we've come out really well on that. So we're looking to keep those 2 stars as we go forward and continue our commitment. A couple more highlights for us. 100% of our patients who go through crisis assessment before admission have had a thorough assessment of their needs before admission over the last year, thanks to the great work that the crisis teams do as part of LPFT and our new psychiatric clinical decisions unit, which is doing great work. The second area we'd like to highlight is that our crisis teams have continued to meet their target, which is to see patients referred to crisis teams and make an initial contact within the 4 hours. It's our equivalent of the 4-hour A&E target. And the teams have been constantly improving the work that they do and have absolutely met consistently that target over the last year. We thank them because it's really important to get that response within 4 hours to people in crisis. The third area we'd like to talk about is our Section 75 contract that we have with the local authority, with Lincolnshire County Council. A really important service where we have our social care, social workers working with us, and we've completed social care reviews and are now meeting the target we're required to for those patients, for those service users. And the fourth area I'd like to mention is our Lincolnshire IAPT Steps to Change. IAPT stands for Improving Access to Psychological Therapies, and we've seen continued strong performance from those teams, which are based across our county. So they are currently meeting higher than expected rates for patients recovering through that service. We're doing well on our waiting times within 6 weeks, where we're significantly above target, and we're improving the access rate so that more people who need that service and are eligible for that service receive that service. In terms of our challenges on performance, we've had some challenges around the amount of money we spend on staff who come from agencies, but we are committed as a board to providing safe quality services, and whilst meeting the agency spend target is important, we don't compromise safety and quality just to meet that target. We've also had some inconsistencies in our performance against what we call the care programme approach, which is about patients who are discharged having follow-ups within 7 days of them being discharged. But we have ended the year above our required 95% target. Again, that's a really important target for us that we take very seriously and we monitor really closely. We know also that physical healthcare checks for our patients, for our inpatients, are important, and we've done a huge piece of work to make sure we are consistently making sure that physical healthcare checks for our patients are available. And Anita, our Director of Nursing, AHPs and Quality, will talk a little bit more about that as we go through our meeting. One area where we remain having challenges is what patients are saying to us as part of what we call our community mental health survey. And that's a survey which asks patients who are in receipt of our community mental health services what they think about those services. We had seen some positive improvements last year in what people were reporting back to us, and we've done a lot of work to try to work hard to make sure we are constantly improving those services, both now and for the future. What we need our public and our patients and our stakeholders to be assured of is the fact that we take that survey really seriously, and we'll be looking to further improve our community offer as we go forward as an organisation. So this year, the year that's just gone, we've seen some huge investment in our services, which has been really, really welcome. But I think it's fair to say virtually every service line, all of our services are affected by change at the moment and are affected by what we need to do to bring additional services so that we can improve the range of services that we provide. And we've had change across all of our divisions, and I'm sure our associate directors will talk about some of that as we go through our meeting. In terms of some of the highlights, we've been able to introduce a 24/7 mental health helpline, which has been a really positive development for our patients, for our service users and for our staff, in that now some people have somewhere to ring 24/7 if they have a mental health issue that they need support with. That's a brilliant new development, and we thank our staff, our partners. So we do that in partnership with Mental Health Matters, which is a key partner for us, but also our clinical commissioning group and local authority colleagues who've helped us put that service in place. That's been invaluable during the COVID-19 crisis, as you'd imagine. In addition to that, we're seeing more and more investment in community services, so crisis cafes, additional community rehabilitation services, which allow us to get our patients safely discharged and supported in the community. And that's a brilliant new service for us, the community rehabilitation service that we've brought on stream this year. In terms of other areas of transformation and improved ways of working, we've had tremendous success in our older adult clinical division with some of the new mental health services they've put in place, including home treatment teams for people with functional mental illness, but also for people with living with dementia. We've got a great new dementia support service, and we've been lucky enough to have one of our older adult inpatient wards, Brant Ward in Lincoln, refurbished. It's a really smart new environment, which is much better for our staff and much better for our patients. In our community division, we've had great success with our veteran services, with our individual placement and support service, which basically provides employment opportunities for people who are part of our community mental health teams. We've introduced a new personality and complex trauma service. We're doing great work with people who are sleeping rough on the streets of Lincolnshire to support those people. We've had great work on our criminal justice liaison and diversion service, and all of that supplements the really fantastic work that our community mental health teams do every single day. And finally our specialist division, where we run some of our very specialist services, including our children and young people service, our learning disability service, our autism diagnosis and support services. So we've seen lots of expansion of crisis and community support for children and young people. We've got a Here For You helpline that we are providing that telephone support to people who need it, and provides a single point of contact and liaison. And through our learning disability teams, we are doing great work to make sure that the cohort of patients who come under the Transforming Care agenda receive the care that they need. So if I move quickly on to some of our achievements this year, we are in the top 10% of all trusts in the National Staff Survey, which is a survey that assesses what our staff think about working at LPFT. That's a great place to be. So for our 2,500 staff, that means that people enjoy working with LPFT and are committed to continuing, hopefully, to do that, and we need to support them. We are rated top in the East Midlands for our junior doctor training, and we have invaluable support from our volunteers who work with us on an unpaid basis to help support our pathways and the patient journey. So moving on quickly to our COVID-19 response, we'd like to say a big thank you to all of our staff and our volunteers for the way they have all responded to the COVID-19 crisis. We have adapted quickly. We have made sure that we've learned as we've gone, and people have stayed with us as we've learned to use PPE, personal protective equipment, as we've worked in different ways to make sure we could still deliver services. We've implemented a huge range of alternative ways of working, including online and digital ways of working, so that we could continue to make contact with our patients even though we were in lockdown and give them the support that they needed. We've upskilled our staff in terms of responding to physical healthcare needs of people who might be affected by COVID-19, and we've extended community support to prevent hospital admission during the lockdown period, as we knew it was more effective to keep people at home. So we'd like to say a big thank you to how our staff have responded. In terms of where we are at the moment, we're moving on from COVID-19. Our staff are now starting to return to their bases with appropriate measures in place, and they have commenced face-to-face working, seeing patients face-to-face, obviously with protections in place and social distancing to support both patients and the staff in that offer. We've increased our digital offer, but it's digital first, not digital only. We recognise that there is an element of digital poverty within our county, and some people don't always have access to either broadband or the connectivity they need. So we're continuing to lock in the benefits that we've learned from COVID-19 by an increased digital offer, but we're making sure that we personalise that agenda as much as we can to make sure people have a service on the basis that they need. So if I just briefly now talk about the changing landscape under the impacts of COVID-19. The impact of COVID-19, we think, means that more people with mental health and emotional well-being difficulties will need to come forward for service. So we're encouraging people to do that. If you have a mental health problem that you need help with, then please step forward. We are open for business, and we want to be able to provide you with the services that you need. We recognise there'll be a big economic impact of COVID-19, and as I said earlier, we recognise that there's potentially more mental health problems starting earlier in childhood, and that we need to support children and young people in school and out of school more effectively. But we welcome the fact that through COVID-19 we're having a very good conversation about mental health and well-being, and that we're working with our partners to make sure that where people need support, there is something available to support them. Part of that support will come from LPFT, and absolutely right, from our specialist services, but we're also looking at different ways of working so that we can make sure that health and wellbeing options are available to people in their local communities, close to home, so that they can get access to the support that they need close to their homes and when they need it. We have something very special, which is a mental health investment standard, which gives mental health better clarity on the levels of funding that need to go in to ensure that we can increase our workforce to respond on the front line of mental health services. And we are therefore seeing, which is really good news, significant investment in our local mental health services to support us with our work. And we're working in partnership with our clinical commissioning group colleagues on that agenda and making sure that if people need a mental health service, they have access to that. I think it's really positive that we're building on changing attitudes to mental health, mental illness and mental well-being that we know are really important. Our partnerships are really important to us. We work in a Lincolnshire system. We work with local authorities, with voluntary, community, social enterprise sector partners, with our clinical commissioning group colleagues, with a range of other organisations, and that's really important to us as a partnership organisation. We are working on what we're calling the Joint Lincolnshire Long-Term Plan that sets an ambitious agenda for all services in Lincolnshire, including mental health, learning disability and autism services. And we are partnering with our colleagues to think about becoming an integrated care system by next April, really working hard to look at how we can integrate what we do with other organisations so that patients see the benefit in terms of seamless pathways, and that as services we see patients as a collective responsibility and work collaboratively with others to deliver services to different people across our county. In terms of our ambitions then, we have ambitions around prevention, so getting in early where we can to prevent ill health and making sure that we have earlier access to support close to home. As I've just said, we're looking at greater integration with others about how we deliver our service. We are absolutely committed to increasing the number of and range of services available in local communities, while making sure that if people do need an inpatient hospital bed for their mental health, we absolutely have those services available in Lincolnshire, and that those are of the best possible quality we can make them. We are looking, as I said earlier, to ensure that our ward-based services are fit for purpose, and that includes eradicating some dormitory accommodation that we still have in some of our wards, and that basically means that people don't have access on some of our wards to their own bathrooms. Some of the beds are in dormitory accommodation still, and that's unacceptable to us as we provide the services that we provide. We are absolutely have an ambition to eradicate that dormitory accommodation, and we're working closely with our clinical commissioning group and regional partners to try to get investment to make sure that we can eradicate that poor accommodation. We are looking to make sure that we repatriate our out of area patients who are inappropriately placed. We are absolutely committed to making sure that we improve access but reduce the length of time that patients wait, and we're looking to introduce new roles, different ways of working to help us do that. We also recognise that we need to retain the wonderful staff that we have, but invite other people to come and work at LPFT, and we'd urge people to keep their eyes out for the opportunities that there are for recruiting into our organisation. And if you are interested in a career in mental health, learning disability and autism, please check out coming to join us as we expand our services. So thank you for listening, and I hope that gives a reasonable summary of some of the work that we've been doing over the last year. We're very proud of what we've managed to achieve, and we're looking forward to doing more in the future. Thank you.
Great, thanks ever so much for that really good summary, Jane, of achievements, also some of the challenges that we've faced and our ambitions as an organisation. We're now going to move to a video piece from Anita Lewin looking at quality. So I'll hand across to that video.
Good afternoon, everybody. I'm Anita Lewin. I'm the Director of Nursing, AHPs and Quality for Lincolnshire Partnership Foundation Trust. I always get the really good part of this day. I get to talk about the quality improvements and the quality agenda in LPFT. So what I'm first going to show you is our Care Quality Commission visits, and these are from April 16 up until January 2019. And as you can see, the fantastic journey that we've made. I did talk about some of this last year, but I think it's important. We have had a CQC visit this year, which I will go on to, but I think it's really important just to show you the fantastic journey that LPFT have come on. So I've made reference to the fact that we had a visit earlier this year, and this was a visit of our rehabilitation services. And as you can see, we maintained our overall rating of good, and we continued with our fantastic outstanding rating for well led. There were some issues that came out of the visit, and I think it's important to note that the time of this visit was at the very beginning of a fantastic transformation of our rehabilitation services. I'm not going to go into detail because you will hear more about that later. But what was clear was the CQC were really impressed with the plans for our rehab services, and I'm very excited to come back and see the work that we've achieved. So I will leave that to the division to talk more about that later. This next slide, I've mentioned it, but I could talk about quality all day long, but there were a couple of bits that I just wanted to pick out that really have indicated some of the fantastic developments and achievements we've made on the quality agenda in the organisation. So research, we have got a fantastic research team with the third largest percentage increase in participation in research projects in all of mental health trusts in the country, which is fantastic for our small team here in LPFT. Sexual safety, the staff from the older adults and adults divisions have led on a patient safety initiative around sexual safety on inpatient wards. Again, a fantastic piece of work, and they have presented on the national stage just the work that has gone on between the two divisions. So again, special thanks to that division, those two divisions, which has helped improve the safety of our patients on our inpatient wards. Physical health checks and staff training, parity of esteem, which is equal measures of physical and mental health and equal interventions around people's physical and mental health. So parity of esteem is really important to us here in LPFT. The physical healthcare team and the staff are doing an amazing job improving the physical health of our patients. We've got a whole new staff training programme, which I have to say has been invaluable at this time of COVID. You've heard a little bit about COVID, you'll hear from it later, a little bit more from me later, but the physical healthcare agenda has obviously been hugely increased over the last 6 months, and our staff have been prepared for this due to the fantastic training programme we have in place. And estates improvements, you've heard over a couple of our last APMs our issues with dormitory accommodation. Fantastic improvement to Brant Ward since last time we spoke, and that has now moved to single room accommodation. We are now in a position where the only dormitory accommodation we have left is in our 3 acute admission wards. We're working hard with regional and national colleagues to get opportunities to remove those dormitories. So watch this space, lots of work going on, and we are working incredibly hard to eradicate dormitories across the whole of our estate. So I mentioned it briefly, but we can't help but talk about COVID-19 and LPFT response. The team, the staff across the board in corporate and clinical services put a huge amount of preparation in between January and March of this year. We could see what was happening in the world. We knew what we needed to do to prepare, and actually the result of those fantastic preparations has been realised in the first 6 months, in the 6 months of COVID that we've had to date. We had the highest uptake ever for LPFT of our staff flu vaccinations. That was 80% of our frontline staff last year. Our infection prevention and control processes, and I'm sure you can imagine, they really have been at the heart of everything we've had to do over the course of the last 6 months. Our infection prevention and control processes have been assessed by the CQC. They have come back and said that We have excellent processes in place in the organisation. They're really impressed with the work that we've done to embed this in everything that we do every day. And just the environmental changes. I've spoken about the dormitory accommodation, but 2 metre distancing was very difficult for us to adhere to in some of our dormitory accommodation. So we have reduced some of our bed stock, and special thanks to the adult inpatient division, who have worked incredibly hard to prevent our numbers of patients who are having to travel out of area to get care increasing during the time of reducing our beds. They have done a fantastic job, but those changes remain in place. We take our infection prevention control very seriously, so those changes will remain in place until such a time that those 2 metre rules are not something that we're having to adhere to. So moving forward to 2021, obviously we are still going to be, and as we are now, in the world of COVID, and things are very different for us. However, that does not stop us in LPFT pushing on with our quality priorities. And as always, they come under the 3 headings of patient safety, patient experience and clinical effectiveness. And with our quality priorities, we look at the events that have gone on in the organisation, we look at the agendas nationally, and we work closely with our divisional teams to set out our quality priorities for 2020-2021. We report regularly on achievement of these priorities, and they continue to be at the heart of everything that we do. So I'm going to finish there. You will hear some fantastic stories later in the day from our operational services, and I'm not going to steal their thunder. But actually, I think the way LPFT has stood up and has managed in this incredibly difficult time, in times that none of us have ever been in before, and every day has been a learning for us. But quality remains the heart of everything that we do in LPFT. So I'm proud to stand here and present some of the quality work that we've done so far, and actually the work that we continue to do every single day. So thank you.
Great, really good to hear from you, Anita, giving us that fantastic summary about the absolute quality of our services and our intent to continue to strive to do the very best for those who need our services. So the final input in this section is on our finances, and I'm going to invite the video from Sarah Connery.
Good afternoon, everybody. My name is Sarah Connery. I'm the Director of Finance and Information here at Lincolnshire Partnership, and today I have the pleasure of presenting the annual accounts for 2019-20. In terms of a summary of the year, to start with some positives, we were able to achieve all of our planned financial targets. That's for revenue and capital expenditure. And as a result of that, we were able, as we did in 2018-19, to achieve a single oversight finance score of 1, which is the best it can be. This basically means we've managed to achieve a healthy financial margin, and we were able to manage our cash in a way that we can cover all of our debts as they fall due. I also wanted to take the opportunity to say, as a real positive from the financial year, is that we managed to complete our Brant Ward capital investment. So this is an investment of over £4 million in total, where we've redeveloped one of our older adult dormitory wards into single ensuite accommodation. This is a clear sign of the Trust reinvesting its past surpluses into improving patient care, and it's making a real difference for service users, staff and carers and families in the care of our older adults. Finally, I just want to highlight some areas of caution around our out of area placement spend in 2019-20. So the system spent 1.7 million over and above plan on out of area spend for acute and psychiatric intensive care patients. This is quite concerning, but the Trust has worked with our commissioning colleagues to work out a plan for investing that money back into local services. The trust underwent significant focus around patient pathways, and to report that we're now back to normal operating levels in terms of our population and capacity, but more on this later. Also, in terms of our progress on community transformation, the system was successful in winning £7 million of additional funding to be spread across 2 years. We were not in a position to be able to invest all of the £4 million that we were allocated for last year due to the timing of the receipts, and also the need to properly engage all of our staff in how that money is going to be invested. But just to report that that money will be reinvested in future years, so it's not lost to the system. Moving on to key financial headlines for the year. This slide just demonstrates the key areas of focus that we go through each month at our trust board in terms of how the trust is performing against its key financial targets. So for 2019-20, we achieved an operating surplus of 1.5 million. You can see how that compares to 2018-19, but just to make colleagues aware that our year-end position is really driven by some of the bonuses that were able to be drawn down in 2018-19, so it was a 3-to-1 regime. That wasn't in place in 2019-20, which explains quite a stark difference there. In terms of capital expenditure, you can see that the trust has invested a significant amount of its cash balances, so quite an increase from the previous year. So that's 5.3 million in total. A great deal of that, 2.9 million, was on the grant scheme that I've previously highlighted, but also investment in improving our community services accommodation, which is also key. Our cash balances remained healthy, so we closed the year at 19.5 million. In terms of cost improvements, we delivered 94% of our plan, which is very positive. But as a word of caution, only 50% of those were recurrent, and it's key that of all the cost improvements that are achieved, that we aim to make them recurrent to maintain that efficiency and productivity. So this is something that our board and our Finance and Performance Committee have really focused on in the year. In terms of NHS improvement targets that have been met, we achieved our control total surplus, but we were unable to meet our agency spend cap of 2 million. We did breach it by only £14,000, but still it's an area that the trust needs to retain quite strong control over to ensure that we're able to work within the cap. But our board is committed to ensure that patient quality services come first as opposed to achieving the cap, which is part of what's driven that performance. I'd like to take the opportunity to thank all of our budget managers across the trust for helping us to achieve this very positive performance. As we all know, NHS resources are becoming ever tight, but I just want to say a big thank you to all of our budget managers to help us to get to where we have at the end of another successful year. Looking ahead, I just wanted to highlight some continued areas of focus looking forward. So an area that we continue to work closely with our commissioning partners is on delivery of the mental health investment standard. This is to achieve that we have parity of esteem with acute physical healthcare services. Also, one that we need to keep in mind given where we are is post-COVID-19 and how that's going to impact on demand for our services and what that might mean for investment in our services. As I sit here today, it's not entirely clear what our financial allocation or financial regime is post 1st of October 2020. So it continues to be an area where we need to work really closely with our commissioning colleagues. Also, we're awaiting the outcome of a bid to Treasury for £37 million of capital to help us eradicate dormitory wards. So this is going to be a really exciting opportunity if we are successful to improve our patient accommodation further. In terms of operational delivery, we're working hard at reinvesting out of area spend to ensure that we're at 0 appropriate out of area placements by 31st of March 2021. And as mentioned earlier, we continue to transform our community services. In terms of collaboration moving forward, the financial regime is going to be one of more system control. So in terms of revenue and capital, we're going to be held accountable as a system for delivery of financial targets. And as part of that, we're working really closely with our system partners in joint development of business cases going forward. So that's my roundup of 2019-20 and a look to the future. So I'm happy to take any questions. Thank you.
Thanks very much, Sarah. It's really important each year that we reflect on how well we have done in spending the large amount of public funds that we get as an organisation. So it's good to have that summary from you. So we're just going to pause for a second to see if there's any questions that have come from the public. So if I could just ask Karen, if you could let me know if we've had any questions, please.
Yes, Paul, we have had one question, and that is from Alan Gerbert. Would the Trust consider developing and running an entrepreneurial programme for nurses and other professionals to develop innovation around local challenges?
Well, thanks for the question, Alan. I'm going to invite Jane Marshall to respond to that, as people is part of her portfolio. Jane, could I invite you to give a response to Alan on that question, please?
Yes, thank you. And thank you for the question, Alan. I know you've always been a great, you put some great ideas forward about how we can think differently about how we recruit and retain our people. And so, yes, in short answer, we are absolutely, as a board, wanting to hear from our people about things you think can help for us to recruit and retain our staff, because we realise as a board of directors, we are only as good as the people we've got. In terms of how you can do some of that, the board has supported the development of what we're calling a new people committee, which is a subcommittee of the board, and some of the thoughts and ideas we have around that people committee and how it will run is that we'll invite our staff to come in and give us stories about their experience of working with LPFT and suggestions and ideas about how we can do things differently. So really welcome the question. Yes, we're up for innovating, and we have a focus through the people committee to bring those ideas together from our staff. So we'd encourage you and others to do that. Thank you, Paul.
Thanks for that answer, Jane. And Karen, I believe we've had another question come through.
We have from Councillor Ron Oxby. The cash balance mentioned earlier, is this cash in hand or what we call reserves?
I think that one, I'll go straight to Sarah on that one, please, Sarah.
Hi, yes, that's a mixture of cash in hand and cash reserves. The cash in hand is minimal, so the majority of that balance is cash reserves.
Thanks, Sarah. Thanks for the question, Ron, as well. I'll just check with Karen to see if there's any other questions that have come through on the question and answers in relation to the presentations we've received from some of our executive colleagues.
No more questions, Paul.
Great. Okay. Thank you very much. That's our review and the end of the first part of this meeting. So that's the formal annual public meeting. What we now move to is our annual members meeting. And we are going to be having, again, a couple of video inputs, which are then followed by a question and answer session. The first of these videos will be coming from our lead governor, Pauline Mountain. Now, unfortunately, we've had a live video glitch from the Trust's end, I'm afraid, which means that for the Q&A piece, we can't have Pauline on video. However, we are hopefully going to be able to ensure that she is linked in via audio to Peter Howie, who has also got one of the inputs in. So we'll be able to take questions. It will be a bit of a mix of technology, I'm afraid, and I'm warned that there may be a bit of a delay, like there is on there used to be on those cross-Atlantic phone calls and things like that. But hopefully we can get a link that does work, and I send apologies to Pauline that we've not been able to include you by a live video link. But let's now move to the pre-recorded video from Pauline, our lead governor. Thank you.
Good afternoon, everyone. I'm a service user governor, and in October 2019, I was very privileged to be elected as lead governor for my fellow governors. I've been a governor for the Trust for 7 years now, and before my election as a service user governor in 2019, I was a carer governor. During this time, I visited services within the Trust and represented the public in a number of meetings and events. So it's my job today to tell you about the work of the governors. The governors are all members of the Trust and all volunteer their time to be governors. The service user and carer, public and staff governors are all elected from the membership of the Trust. We also have some governors appointed by organisations who work most closely with the Trust to deliver care for people with mental health and/or learning disability needs. Governors have two main duties. One is to represent the membership and the wider public. The other is to hold the board of directors to account for the performance of the Trust, and that's via our non-exec directors. We ensure we carry out the two duties I've just mentioned. Governors attend a Council of Governors meeting where those duties form the most important parts of the agenda. As well as doing this, the governors give their views to the Trust to ensure that needs of the public are included in the Trust's strategic plans. We are given the opportunity to read and to comment on the Trust's annual report and accounts so that we can understand where the Trust is doing well and challenge any areas of underperformance. Quality is an important part of what the Trust does, and as governors, we agree the Trust priorities and review the annual quality report. As a Council of Governors, it is our responsibility toward the contract for the external auditors. A moment ago, I mentioned that one of our Council of Governors' responsibilities is to represent its members. Anyone can be a member of the Trust, and joining is easy. People just need to complete a simple application form. From those of you who are members, thank you. And for those who aren't, please sign up today by contacting Sam Swindell, who is our Governor and Membership Officer. It's easy to do, and details of how you can do this can be found on the Trust website, www.lpft.nhs.uk. On the 31st of March 2020, there were 9,766 members, and we continue to recruit new members. Go on, let's get us to 10,000. You can do it. Please do ask your family and friends to join as members of the Trust. We'd welcome you. We meet on our members at many different places and provide information to them in both written and electronic format. This year we have engaged with members by holding today's public meeting, albeit under very different circumstances, by holding all of our council meetings in public and publishing all of our agendas, meeting papers and minutes. Generally, our meetings are recorded, which enable anyone to view via the website. We produce a printed Better Together magazine twice a year, and between times produce an electronic version of the magazine. Both are always available via the website. As governors, we visit services and meet service users in a variety of settings, including public events and a range of groups and committees that are run by LPFT and other organisations. As governors, we want to hear about your innovations and ideas that members of the Trust and the general public can give us to help us to contribute to the Trust's future plans and to make services better in a co-produced approach of inclusion. The feedback you give us enables us as governors to influence key decision makers, both within the Trust and in the wider health and social care organisations in Lincolnshire. Sometimes, where issues relate to individuals, we are able to direct concerns to the appropriate service and help produce immediate improvements. You have heard from directors about the Trust's quality and financial performance. As a Council of Governors, we regularly receive reports through a variety of routes, and we hold the board to account, as I mentioned earlier, via the non-exec directors, who provide assurance reports to every Council of Governors meeting. Governors have the opportunity to directly contribute to the Trust's agreed quality targets and are particularly keen to review the Trust's progress against the Care Quality Commissioner's outcomes. I would like to take this opportunity to thank you on behalf of myself and my fellow governors for joining us today and supporting the continued work of the Trust. I hope this time next year we will be able to meet again in person. I'm now going to hand you over to Peter Howie, our Trust Secretary, who will provide you with facts and figures around our membership and the requirements of the Constitution. Thank you and enjoy your day.
Great to hear from you, Pauline, and thank you for that summary from the perspective of the lead governor. We're going to move, as you suggested there, to the input now from our Trust Secretary, Peter Howie, and then we will have an opportunity for some further questions. So over to Peter, please.
Hey everybody, I'm Peter Howie, I'm the Trust Secretary. As part of the statutory duties of at the members' meeting, I'm required to inform you of changes to the Constitution that have occurred over the last year. In the last year, there have been 3 specific changes, one of which is to extend our surrounding areas class to a Rest of England class. That allows members from all over the country now to be members of the Trust. We've done this because of the changes to the services we provide being much wider across the country now, and the influences we have over services in other parts of the country. The Council of Governors approved this change in January this year. Also in January this year, the Council of Governors noted that there would be changes to the Lincolnshire Clinical Commissioning Groups into one Clinical Commissioning Group. The Constitution has therefore been changed to reflect that, and that the one representative will be from Lincolnshire Clinical Commissioning Group, as opposed to one representative formerly representing 4 groups. Later on in the year, in July, the Council of Governors and the Board of Directors reviewed the disqualification criteria for staff governors. And one of the additions that was placed was any member of staff currently subject to a live disciplinary sanction would not be eligible to be elected as a staff governor. The Constitution itself will be reviewed again during the current year. Therefore, just to confirm the current constituencies and the classes within the constituencies, the main constituencies themselves have not changed. The only specific change is, as previously mentioned, that the former surrounding areas class within the constituency is now the Rest of England class. Our membership numbers have changed slightly since the previous year. You'll see there are changes that have occurred across each of the different constituencies, and the current membership numbers are at 9,766 as at March 2020. As well as the overall numbers, we are required to have a representative membership. All of the areas of our membership are representative, with the exception of the gender split, where 25% above the normal representation level are female. female membership within any membership organisation is known to be higher, and there is no particular action that we've taken that would have created this to happen. I do need to report on the elections that were held in 2019-20. The elections in 2019-20 were service user and governor elections. Service user and carer governor elections. These were held and the governors took up their seats for 3 years from the 1st of October 2019. Elections were held for one of the specialist services seats and public surrounding area, the public city of Lincoln and West Lindsey. These were all by-elections that were held in attempt to fill vacant seats. One seat remained unfilled, which was the West Lindsey seat. We have now commenced the elections for our staff governors. And the elections for our staff governors for 2021 being held now, and we will be announcing later in the meeting the successful candidates who will take up their seats from the 1st of October 2020. We will also be completing by-elections this year for vacant seats, which are public seats in the Borough of Boston and West Lindsey, who will also take up the seats from the 1st of October. And I'll give you the opportunity to ask any questions in relation to the membership of the Trust.
Thank you very much for that, Peter. I know that some of that is quite technical, but it's really important that we do that formally. We now get an opportunity for any further questions, and actually there's one that I wanted to ensure we picked up. Karen, I think there's an additional question in relation to one of the earlier presentations.
There is a question from Hannah Blevins, and this refers to the presentation from our executive directors. You acknowledge that the mental health situation post-COVID is a priority. What additional provisions are you putting in place? Will there be funding available for third sector projects working directly with service users?
Great, thank you very much for that question, Hannah. Both parts of that are really important. Jane, I think if I could invite you to respond to that one, please.
Thank you, Chair, and thank you, Hannah, for the question. It's difficult for me to find the words to say just how important it is that we prioritise community efforts to help support those people coming through post-COVID. And I believe you're part of the Askerfield Farm project. I think you are, which is funded through something we call the Managed Care Network, which as an organisation we've been lucky enough to run for 8 years over 10 waves of funding that we received from Lincolnshire County Council. So as part of our recovery work, we're required to put in place plans to recover from the first wave of COVID. As part of our recovery work and to cement that commitment that we have to helping people live well in their communities, which is our vision, we have produced something that we call the universal offer, which is not at all services that are run by LPFT. They are precisely those kinds of services you mentioned in your question, run by our colleagues in voluntary, community, social enterprise, third sector organisations who are much better than we are at doing that work to support people. And yes, there is funding now. Through the universal offer, we're making the case for even more funding, because we know that for every £300,000 we have to spend through Managed Care Network activities, there's always £1 million of proposals coming through from our third sector partners. So we know we need to scale up the amount of money that's available. And if it's okay with you, I've been passed your details by my colleague Chris Higgins, our Director of Operations. So I'll be in contact with you later today to speak specifically about the work you're involved in. Thank you, Paul.
Thanks for that answer, Jane. Appreciate that. Karen, have we received any other questions?
We haven't, no.
Okay, in which case I'm going to move on to the next piece of our annual members meeting, which is to invite Peter Howie to give us the election results for governors. I'm hoping that Pauline, our lead governor, will be able to give an audio response after we've heard from Peter. So Peter, if we could move across to you, please.
Peter, you need to unmute.
Yeah, thank you, Paul. I have the results here from this year's elections. This year's elections are for staff governors, and there are some by-elections for other governors. So we'll do the by-elections first. The by-election for the public governor for West Lindsey, the elected candidate is David Doherty. The by-election for the borough of Boston, the elected unopposed candidate is Councillor Brian Rush. Then we go on to the staff seats, and for our staff specialist services, through a contested election, Lisa Norris has been elected for a second time. Sunith Sibadani has been elected for the first time, and she will replace George Badiale, who was not successfully elected. In the corporate team, the previous Governor Sophie Ford has stood down, and following election process, Laura Suffield has been elected as the staff corporate governor. Then move on to adult inpatients. Joby Costello stood down this time and didn't stand again for election. Following the contested elections, the two governors elected were Helen Smith and Drew Rowley. In the older adult seat, we had two uncontested candidates, both previously governors, that's Jackie Tyson and Suzanne Ridley, who are now elected again. In the adult community division, there were contested elections. The two people who have retained the seats that they stood again for are Christine Cooper and Mithilesh Jha. We should also say is there have been some other governor changes recently. Rebecca Metso started with us as a service user governor, and she replaces Millie Allinson, who has moved on. That also meant we had to replace Millie as the deputy lead governor, and Giles Crust has taken on that role. We've also got Ingrid Gill returning to us as a governor, who replaced Tracy Roberts in a deputy role. So that's all of the governors that have been elected and the changes that we have had. I'll let Pauline speak now, and then I'll come back after Pauline's spoken.
Hello, can you hear me?
Yes, we can, Pauline.
Thank you. Thank you, Peter, for doing that update. And really, I'd like to congratulate everyone that applied, first and foremost. Congratulations to the successful candidates and commiserations to the unsuccessful. But please do continue to support us as a council of governors. You can always feed your comments into any elected member, I hasten to add. And I look forward to welcoming you at both the new and the re-elected members of the Council of Governors in October at our meeting then. So thank you very much, and yes, look forward to a very exciting year ahead with new staff members and a full Council of Governors. So thank you very much, and thank you, Peter, for doing that without in my absence and my not being visible. But I hope you can all hear me, and thank you.
Okay, yeah, thank you, Pauline. I understand, I can see from other signals that everybody can hear you and hears what's going on. Paul, if I may, just before I do hand back to you, I'd just like to place on the record the fact that this will be your last annual public meeting after 6 years. I think everybody would be wanting to say thank you for doing a fabulous job of the last 6 of these. Obviously, there's going to be lots of formal thanks at various things later in the year or next year, but as this is your last formal meeting, I just want to formally place on the record on behalf of the whole trust, the council and the board, our gratitude for how well you've done this. So I know you didn't know that was coming, so apologies, but thank you.
Can I add something, Peter?
Yes, Pauline.
I think we as a council of governors do have the opportunity to put our chair in place, but we really do not want to take him out, as the saying goes. And I have suggested that we put lead boots on him, but all has failed because statute says, unfortunately, he has to go, and that's the way in which the system works. So we are very sad to see you go, Paul, and you will be a hard act to follow. I'm sure our congratulations go to you, but more importantly, our absolute thanks and public thanks from all of us as a council of governors, and especially me as the lead governor on your departure. And there's still time for me to keep those lead boots on, you know. Take care and thank you.
Okay, therefore we'll hand the meeting back to you now.
Thanks very much for that. I am a little gobsmacked. You're right, Peter, I wasn't expecting that. Thank you, both you and also Pauline, for your kind words. And just to say to people, I am still around for 6 months or so, but as Peter acknowledged, this was my last annual public meeting, and I really appreciate those kind comments. Thank you. So we've then come to an end of the annual members meeting. Now, an important part of our usual annual meeting is really showcasing some of our services. And what we usually do, of course, is have a very physical presence with lots of stalls, and to enable our services and indeed services from partners in the community and third sector to be able to connect and show some of the very many things that we do for the local community. As we can't do that, we are able to have some presentations from a number of our services that are broadly representative across the range of services we have as an organisation. And we will be going into a series of presentations in a little while. What we suggest we do, it's good practice when we're on these video and digital links, is that we take ourselves a short comfort break, and I'm going to suggest that we take 15 minutes, so we restart at 2:45, and we will come back together and have again video inputs, but also we have staff colleagues who are on hand to take questions in response to the different videos that get presented. So I'll pause there and we'll come back together at 2:45. Thanks very much, everybody. So, welcome back, everybody, and we're moving into, you can tell it's slightly more relaxed than the formal setting, so I've taken my jacket off. So we're moving into the presentations from a number of our services, and to start us off, we're going to move to a video from our community services, which is presented by Anne Harris, Victoria Slate and Dr. Ramesh Shankar. So let's go to that video, please.
Summary of the Trust's transformation of community services. For the digital offer, work had already started prior to COVID-19 to ensure that we increased access to services by offering digital and remote working. However, the plan to introduce this slowly and roll it out over a 2 to 3 year period with steps to change and our early intervention service using Vitra Care was escalated due to the COVID-19, which forced us to react quicker in terms of delivering a digital offer. The Vitra Care is a digital platform that Steps to Change and the Early Intervention Service have worked with our commissioners and providers to develop bespoke platforms unique for their service and service users. Our Steps to Change service moved to a remote and digital working in days using WebEx and Q Health. However, the digital offer is not for everyone, I would like to say, and it is in addition to the normal working practices of our services. Within the CMHTs, we extended our service provision for the community mental health teams. So what we did, our community services rapidly extended their offer to a 7-day working in order to respond, offering early intervention across the 7 days to patients whose mental health state presented and indicated that they were at risk of immediate deterioration or relapse. This was quite unique, as nationally, talking to colleagues at the Royal College of Psychiatrists, most community services and CMHTs had actually reduced their offer.
Thank you, Anne. I will be talking about the medical resources and leadership. We all know that we are going through a real unprecedented situation in living memory. And from history, we know as a human race, we have gone through multiple pandemics, including the plague, where we lost nearly 75 to 200 million humans across the planet. And this invisible organism, the virus, has kept many of us inside, and the whole world has turned upside down due to this pandemic. And whenever human race goes through crisis situation and healthcare scares, we always look forward to healthcare workers on the front line to come to the fore and help out with the situation. And we always look forward to the experts in that field of healthcare. And as doctors, we are expected to engage and provide leadership. And I'm really fortunate to have a fantastic cohort of colleagues within our division who voluntarily put their hands up to support us. In terms of provision of outpatient clinics, we have continued to maintain the same level of care. We have not shortened our outpatient clinics. We did manage to continue to assess patients in the outpatients face-to-face as appropriate, but most of them are through digital virtual clinics. And most of the patients and service users and families, they are more than happy with the digital offer, but some did request for face-to-face, which we provided as appropriate. As these are unprecedented situations, we needed to have a safety net. Hence the reason, despite our normal MDT working, we have to enhance our discussions in the MDT to make sure that every patient had the best possible care package put in place. As we continued the normal outpatient clinics without reducing the number of patients, we had been more than efficient with the number of patients being seen in many localities, and hence there has been no increase in the waiting times of the outpatient clinics.
I'd just like to just go through the next couple of slides, and these are just some examples of some of the additional support packages that the teams have used to support service users again during this period. The Recovery College has continued to deliver courses online. We've provided self-help guides, coping skills toolboxes, coping skills bingo, anxiety management quizzes, and these are all additional resources to try and support service users to maintain their well-being during this period. The next slide again is an example of an initiative from the Skegness Community Mental Health team. These were a virtual craft group. So the staff and volunteer at Skegness team developed these craft boxes. They were delivered to service users' doorsteps, and then they were able to virtually still maintain a craft group. And Victoria, now to you. Thank you.
Thank you, Anne. So community mental health transformation has been talked about quite a lot, I think, over the last few months. And this afternoon, I'd really just like to get some key messages across to you around what that really means. So from an overview perspective, it's really about making sure that all the services in the community are joined together and they can support you then in the way that you need them to do so. And when we talk about services, what we mean is all the services that we offer here in LPFT, plus working with our colleagues out in the wider system. So thinking about charities, voluntary sector services, people that you will be very familiar with within the council, to ensure that we wrap that care right around you and make it easier for you and your family to access the support you need, and importantly, when you need it. And I think it's a really important point to think about that when somebody's in crisis or suffering with a serious mental illness, often their family are providing a huge amount of support as well. So transformation wants to ensure that everybody gets the support that they need. We've also listened to you, and we know that sometimes it can be difficult. We live in a large rural county to be able to access the services that you need. So we want to make sure that you're able to do that in the heart of your community and maybe be able to walk to the services rather than travel on a bus, but ensuring that all the time you're growing the network of people around you that will support you to keep you well. This slide is to try and help you understand how all of these things might work together. So there are 4 key elements on this slide in the red circles. The community hubs. These are hubs that we've developed together with you within the community and many other charities and voluntary sectors. People like the co-op are involved, your normal sort of everyday services, even down to local shops, so that you can work together and be able to access these community hubs and maybe even find a role that you can provide in there. On top of that, there'll be some crisis cafes across these sites within the county that you can access 24 hours a day, 7 days a week, 365 days a year. And at the moment, the crisis cafes are running overnight, so often providing services where traditionally it may have been more difficult to access them. At the heart of all of that is making sure that there's no wrong door. Never should you feel as people that you can't find the way into a service, and that actually you are the person that's in control of your care. So we want to make sure that by providing well-being for everybody, we support each other. So we're very heavily linking things to an agenda that's within our work around what matters to me. So listening to you so that you tell us what matters to you rather than we do to you. To help support us, as Anne mentioned earlier, we are using some digitalisation work. And the aim of that is, as Anne very rightly said, it's not to replace the service, it's to add to. So we are looking at things like VitraCare, we're looking at things like putting points into our community hubs, into our GP practices, into our libraries, to help you to be able to access that technology. We're also making sure that all the way along this, we are working with you. So we are co-producing what we do. We want to listen and respond. We want to make that difference to you. And we genuinely want you to feel that you own this transformation. Importantly, we want to make sure that it lasts and that it's sustainable. So as we move through this, we're making sure that the funding and the way that we can develop these services is able to be owned by you as a community with our support. We've talked about how we will make sure that you can access those services, and again that is about walking in. There will be opportunities for you to walk in and there will be no wrong front door. We'll make sure that that no wrong front door is easy to access, so even if somebody's in crisis in the middle of the night, they will be able to access a crisis cafe such as the Nightlight Cafe that's now running in Lincoln, and that can be through a telephone call to our helpline Mental Health Matters, or it could be through a digital connection, or it could be through a referral from maybe one of our social prescribers or one of our community teams, as we've talked about, who provide you that massive amount of support. But most importantly, and what I'd really like to finish on, is we want to listen and we want to work with you. So we need to make sure that you're able to tell us what we need to do and make sure that we're really delivering the services that matter to you. So we will welcome your feedback, and we would like to make sure that you have a voice so that you own your services. Thank you.
Okay, so that's the end of our presentation for this afternoon from the Adult Community Division. If anybody's got any questions, we're happy to answer. Please go ahead.
That's great. Thanks ever so much for that presentation, and Victoria and Ramesh, it was really good to see and to hear such a breadth of services too. So if I could just check in with Karen to see if we've had any questions come through in response to that particular presentation.
No, Paul, we haven't had any as yet. The presenters will stay in the meeting for a little while after the presentation, so if there's anything that comes in a little later, they will be around to answer them.
That's great. Thank you very much. In which case,
sorry, we have now got one.
Great, Karen, if you could.
So one's just popped in. So what are the location of the crisis cafes?
Great, good question. So I'm going to pass that across. I think we've got Nick Harwood, Jess Howland, and also Dr. Shankar who are available. So if I pass that question across to you, Nick, and you can work out who's best to field a response to that on the location of the cafes.
Thank you, Paul. That's actually a really good question, and one that I'm not actually cited on. I'm hoping that somebody can help me out here. I know there is most certainly one in Lincoln, and the others are work in progress essentially, but I might need some help with answering that question more specifically.
Should we, is there, do either Jess or Ramesh have an answer to that, or perhaps any of our colleagues in the executive team? I've got a suggestion that Chris Higgins, one of our directors, has suggested that we come back afterwards to make sure that we get that information out so that we can be really clear about either where those cafes are or indeed where they're planned on being. So, excellent. Okay, sorry we couldn't give you a specific answer there, but rather than make guesses, we'll make sure that we come up with proper information after the event. Are there any other questions coming through, Karen?
No more, Paul.
Actually, I think
they're coming in.
Yes, we have got another one coming in. We're just keeping on track. So, Karen, could I ask you to give us that next question, please?
So, a question from F. Garcia. Does the community team have established links with teams supporting patients living with substance abuse issues?
Thank you for the question. And again, if I could pass that one across to Nick to get that one fielded in the most appropriate way. Nick.
Yes, thank you, Paul. I mean, absolutely. Comorbid difficulties are common amongst some of our patients, so we have to take into consideration any substance misuse that is apparent. We're not the provider of the substance misuse and alcohol services in the county at the moment, but there's clear links across. So we do have good relationships with We Are With You, and it's certainly part of our assessment protocols to ensure that that people's needs are met when there's those kind of dual issues going on. So yeah, absolutely fundamental in some of the work that we do.
Great.
Paul,
Ramesh. Yeah, Ramesh.
Yeah, can I just add to what Nick has just alluded to? We in the CMHT, we do continue to provide service for patients with both mental health and addiction issues. We work closely with addiction. And as you all know, that we also have the Rough Sleepers program board, and one of our doctors is heavily involved with that. So we continue to work closely with all the stakeholders, even though we do not have a dedicated dual diagnosis service, since we are not providing the addiction service. We are currently formulating a pathway for the dual diagnosis. Yes, currently we are providing service for mental health issues with patients having addiction problems.
Ramesh. Thanks very much for that, Ramesh and Nick. And it's a really important question around that dual diagnosis, and good that that partnership work is continuing to progress. So, Karen, does that cover us off for questions in relation to this presentation?
Specific questions, but I think Chris Higgins, Director of Operations, would like to come back on the...
Chris, is there any, would you like to stick your camera on and give us any additional piece of information around those connections to addiction services? Chris.
Yeah, thanks, Paul. Just to say that there's partnership working that goes off across our teams with our partners who are We Are With You, the substance misuse provider. But obviously there's always more work to be done, and actually we're just about to embark on a piece of work to look at how we can strengthen both our policies in LPFT and those of those in We Are With You, so that we get better alignment across both providers, and that will really hopefully strengthen the work that the clinicians can do on the ground, so that there's that framework that sits behind it to make sure there's no gaps between provision, as sometimes can be the case. So our medical director Nancy Darby has been instrumental in some of that work, and we'll be taking it forward over the next few months. So more to see on that one as well.
That's great. Thanks very much, Chris. And Karen, I think there's been one more question come in.
There has. So, is there a plan for changes in hospital discharge when people are homeless?
That's a great question. Nick, do you can I pass that across to yourself and Jess and Ramesh as a start?
I think Paul, essentially around that question may come into the inpatient presentation if it's around hospital discharge. Obviously, we're looking at providing the community services. It's really important in any offer that we're looking at in the community that we are adding accommodation and housing to the kind of issues that we're looking at for people. So it certainly is a piece of work that's ongoing and a piece of work that will progress further in regards to ensuring people have good quality accommodation to go into from hospital or just in general. I think Chris has perhaps come in because to add something to that.
I was going to suggest that I think if Eve Baird is able to put a camera on, I think Eve could give us a bit of additional response to that question. Eve, are you there?
Hi, yes. Can everybody hear me? Yeah, brilliant. I think this is a really good example of why it's so important that we work across all our services to provide one clear pathway for patients, because the challenges around discharging patients are challenges that we have to address as an inpatient service when we're supporting patients to move towards discharge, but that we need to keep focused on as people move back into community services. We're doing a lot of work at the moment with the local authority. So we've just done a bit of a stock take of all our current inpatient patients, their current accommodation status, and any challenges that we're facing with individual patients around finding them suitable accommodation when they're discharged. So we're trying to work as a system, both across LPFT but also across the wider Lincolnshire system, to address some of those challenges that we know we face with people who struggle to maintain tenancies at times because of the challenges that they face. It's a really important piece of work for us, and like as I say, we're working on that. We've had some real successes with engaging with some third sector providers around, so we're working with P3, who are supporting us to provide accommodation for people where it's previously been difficult for other providers to agree to tenancies because of historic challenges around that. So it's a piece of work where we're making a lot of progress, but there's still a lot of work for us to do.
That's excellent. Thanks ever so much for that, Eve. Thanks ever so much to our community services colleagues for the presentation and those Q&A. And we will make sure that additional information will be that was requested will be put out there. We're actually going to move now into our adult inpatient services and a video from Eve, who we were just hearing from. So if we could move into that video, please.
It's in the division of COVID-19. What that's meant for us and our patients, and how we're moving forward from those experiences. So at the start of the pandemic, we had a number of priorities within the division. We had to respond really quickly to national and local priorities, as well as ensuring that we kept services running and accessible for individuals in crisis and individuals requiring inpatient care. We didn't have the option to not deliver services, so we had to take on board everything that was coming out nationally and work out what it meant for us and our staff and our patients in the context of still needing to deliver services. We had to make sure we'd got appropriate processes in place to minimise the risk of spreading COVID and keep our patients and our staff safe. At the same time, we needed to bring the people being cared for in our out of area beds back to local services, so that private providers could be part of the national response to COVID if required. There was lots of discussions around freeing up private providers to be able to become COVID wards if that was needed. It became clear as time went on that the rate of hospital-acquired infection was far higher than community transition of the infection, and this meant that we needed to be even more focused on avoiding hospital admissions wherever possible and keeping people in hospital for the shortest time possible. What that meant for us in terms of changes to our service in response to COVID was that we had to make a lot of changes very quickly. The biggest one was around enhanced infection prevention and control methods. This included use of protective equipment, and that was really difficult. The guidance changed frequently, particularly at the start. Our division was really well supported by Jane Lord and the IPC team to interpret guidance in the context of our own service, because a lot of the guidance coming through wasn't mental health specific, and make sure that we were advising staff and patients appropriately. We had to make a number of environmental changes across our services. These included changing the function of certain areas, for example, introducing isolation rooms in case patients presented as symptomatic. And we also had to think about how we would change our use of our inpatient estate if we ended up nursing people who had confirmed cases of COVID-19. In addition to this, we had to reduce the number of beds on wards with dormitory accommodation and on one ward with limited shared space to ensure that we could facilitate effective social distancing. We had to introduce new admission and discharge procedures, and this included encouraging patients to isolate while we waited for test results once they'd been admitted or pre-discharge. This was particularly difficult on wards where we were admitting people who were struggling with their own mental health at that time and helping people to understand and comply with the guidance. We had to change visiting procedures. That was really hard for patients. We went from having no visiting to facilitating the majority of our visiting in outside spaces to try and minimise the spread of infection. And we had to change guidance around leave from our inpatient wards. So we encourage patients to use limited leave so that there was less chance of people bringing infection back onto the wards once they've been off the wards. We looked to increase use of digital solutions. For our crisis and home treatment team, this included alternatives to face-to-face contacts, but also for our inpatient wards, we were using digital solutions to support ward rounds and MDT meetings, tribunals, hospital management hearings, and then we started to look at digital solutions to some of the Mental Health Act paperwork, so looking at the use of e-signatures rather than people having to be physically present to provide a signature. We needed to look at increased options for alternatives to admissions. The community teams worked with us on this and started to offer 7-day-a-week services, and we looked at increased opportunities for intensive home treatment. As well as this, we were looking at increased options for discharge from inpatient care. There was a trust protocol agreed that gave specific guidance around the threshold for admission and discharges to inpatient wards. We also set up at pace a step-down accommodation service in Ash Villa, which had previously been an inpatient unit. And we revised agreements with partner organisations. So we agreed changes to admission criteria for our crisis houses to ensure that we could support people to leave inpatient services as soon as they were safe and they were ready to do so. We've taken loads of learning through our COVID-19 experience so far. Our patient and carers have been impacted hugely by some of the changes we've had to make. Our patients have faced increased restrictions during their inpatient admission. And we've been really mindful of that. We've sent out patient experience questionnaires to all of the patients who have been inpatients during this time. The feedback we've had so far from the questionnaires that have been returned is that 80% of our patients felt they were provided with information around COVID-19. They did feel safe on the ward. They felt able to discuss their concerns and anxieties, and that they had enough access to fresh air whilst they were on the wards. I think it's important for us to look at that other 20% and understand what didn't work for them and what we could do better. For our crisis teams, we've also sent out patient questionnaires, and of the questionnaires returned to date, 100% stated that they were advised of how to access support in a crisis during the pandemic, which is really positive. 80% rated the advice they were given from the team as good or excellent. And one really key piece of learning for us is that the overwhelming feedback and comments were that patients preferred face-to-face contact for a variety of reasons. I think it's become clear that when someone is in a mental health crisis, they really value having someone to talk to face to face, whatever precautions we have to put in place to make sure that can happen. A number of their comments included that it was difficult to talk over the phone. They feel that more time was given if it's face to face and it feels more personal. And also people talked about feeling better to see someone when they're opening up about personal issues. I think we learned a lot through our staff experience as well. We were asking staff to go out and see patients at a time when none of us really knew what COVID could do. So when the rest of the world was in lockdown and the message was stay home and stay safe, we were asking our staff to go out and continue to offer a service to our patients in crisis and on our inpatient services. Our staff showed huge courage, bravery and commitment by stepping up and seeing the most vulnerable in our society when we needed them to the most. The messages that have come back from staff around that time is the importance of timely communication and guidance. And I think one of the key things that I've taken from that is that even if the message you're giving is we don't know, that's still a message staff want to hear because they want to know the truth. They want to know what's happening, and a real desire from our staff for consistency of approach and advice. So one of the clear messages that's come back from staff is one of the things that was most challenging was if they felt they were being given inconsistent advice. I think it's been a real challenge for me and for other members of the management team to strike the right balance between avoiding unnecessary visits to wards and teams in line with infection control guidance and providing visible leadership and opportunities for support, staff to ask questions, give feedback and us to learn from experiences. I'm not sure we've always got that right, but it's something that we've been really mindful of and we've worked hard on. In terms of service delivery, I think there's been lots of learning for us in terms of the impact of numbers of people accessing services. So early on during COVID-19, we saw a decrease in people accessing crisis services. I think as the message was stay at home and stay safe, lots of people seemed to take that on board to an extreme and perhaps not seek help when they needed it. Further down the line, we've then seen a significant increase in people accessing crisis services and a steady increase in people requiring inpatient admission. This has had an impact on our ability to safely staff services and make sure we've got the right contingency plans in place to be able to deal with the fluctuations in need that we're seeing, but also to be able to deal with the changing impact of government advice. So, for example, the impact of test and trace on our ability to staff services safely as lockdown rules have been lifted and people have had more opportunities to mix with different groups of people.
Despite how it's felt at times, COVID hasn't been the only thing happening in the inpatient and urgent care division over the last 12 months. Moving forward, we will take on learning from all of our successes and challenges over the last year. In October last year, we secured funding as part of Lincolnshire's Community Mental Health Transformation Bid to accelerate our existing plans for the transformation of our rehabilitation services. We have recruited to a community rehabilitation team that was fully staffed by the end of April 2020. The aim of the team is to support individuals with mental health rehabilitation needs in the community, where previously the only rehabilitation option in Lincolnshire was an inpatient admission. The team is actively working with over 20 patients currently in inpatient services and has an ambitious target of supporting the transition of 15 of those patients to community rehabilitation services by the end of October this year. The CQC visited our rehabilitation services in March 2020, and the teams demonstrated the high levels of compassionate care they offer our patients. We retained our overall rating of good for our inpatient rehabilitation services. We were disappointed to be rated as requires improvement for delivering effective services, but we're using the feedback from the inspection team to inform the further development of transformation plans that were already underway at the time of the inspection. This year, we're building on previous engagement events with patients, carers, staff and other stakeholders to share our learning so far and hear more about people's experiences of our current services and their ideas for the future. The next 12 months is an exciting time for mental health rehabilitation in Lincolnshire as we develop a reablement pathway within inpatient services, expand community rehabilitation services, and review and update the purpose and function of our inpatient units. Across all of our inpatient and urgent care services, we're continually reviewing guidance and procedures that were put in place in response to COVID-19. For example, we are currently reviewing our visiting policy now colder weather is coming. Over the summer, we encourage patients to meet friends and family outside whenever possible to minimise the risk of bringing COVID onto the wards. As we head into autumn and winter, we're putting processes in place to support safe visits within our inpatient units. Our teams continue to work hard to ensure care is person-centred and meets the needs of the individuals involved. The Trust is committed to maintaining bed reductions in our inpatient units until requirements regarding social distancing are no longer in place. As the Trust's commitment to eliminating inappropriate out-of-area acute placements also continues, we are mitigating the reduced number of beds available in county by opening Ash Villa as a 15-bedded female acute treatment ward. The divisional team is also working with other teams in the Trust to develop plans to eradicate dormitory accommodation across our inpatient units. Our ward teams, crisis and home treatment teams and community mental health teams will continue to work together to avoid unnecessary admissions and support safe and timely discharges from inpatient care. These teams are also working alongside other partner organisations, including the local authority and third sector providers, to ensure we have the right packages of health and social care for people as they leave hospital. Within the division, we're building on the use of digital technologies to support contact with patients and carers, but also to support integrated team working. Ward rounds and MDT meetings are now generally accessible through digital mediums as well as face-to-face. This is really important for us in Lincolnshire, given the huge geography that some of our specialist services cover. My final comment in relation to moving forward is that we can only continue to deliver safe, effective, responsive and compassionate care to the people who really need it because of the commitment and resilience of our staff teams. I've been proud to be part of LPFT's inpatient and urgent care response to COVID-19, and I'm confident that we will continue to build on our learning so far over the coming months. Thank you for listening. Any questions?
Thanks ever so much for that great presentation, Eve, and it's really good the way that you described that slide, the new normal. It's one of those phrases that I think that we are getting used to hearing, that actually you really gave depth to that for us. It was excellent. So again, I'm just going to check with Karen to see if we've had any questions come through. Karen?
No, we haven't, not as yet, Paul. I'll keep my eye open in case there are any last minute ones.
Okay, in which case, what I suggest we do is if we move on to our next video input, what we will do is we'll take a break after this next video input, but we're going to move to hear from our older adult services. And I think on the video, the presentation is coming to us from Steve Roberts, Dawn Parker and Dr. Collins Asiwe. And I think Steve and Dawn are also both available live with us if there are any comments or questions to follow through. So if we could go to this video, please.
Good afternoon, everybody, and thank you for joining us in this unusual and unique method at the annual public meeting. And we are the Older People and Frailty Division. And first of all, to introduce ourselves, my name is Stephen Roberts. I'm the Associate Director of Operations for the division.
Collins Asiwe, Clinical Director for the division.
I'm Dawn Parker, Quality and Assurance Lead for the Older Adult Division.
And we're going to talk to you briefly about moving on from COVID-19 and exploring the possibilities of the new normal, as it's been called. And during that, basically, we'll give you a brief run through of the challenges we faced as a division and how we responded to those. But in talking about how we responded to them, telling you some of the lessons we've learned and the things that we're hoping that we can continue to do after COVID or as the situation progresses into the long term. So we're going to kick off first of all with Dawn, talking about the challenges and opportunities that this current situation
Thank you. I don't know anybody that wouldn't say that COVID has been a challenge, both on a professional and a personal level, and in delivering, particularly in older adults, our services. We know that shielding and isolation impacted on our patient group, who were told largely to stay at home for numerous reasons. This meant, as a service, how would we rise to the challenge of engaging with people who've been told to stay home? We know that access to certain services became very limited or shut down completely. We know that the care homes went into lockdown on advice, with the compounded problems of unmet need within care homes. We know that staff were also having to shield, and how do we deliver care differently with staff working from home and needing to do things differently. We also needed to prevent admissions because of the risk of admission from COVID itself and how that would impact on our patient group. And also, how do we provide, when things are closing and shutting down, how do we ensure that our patient group and our carers have access to our services? We know, particularly from our engagement over the last 2 or 3 years, that out of hours, that weekends, that crisis time was a time that they wanted to make sure that people had access to support. And how do we protect the most vulnerable within our caseloads and our patient group? And how do you do this at a pace when the pace is dictated by things outside your control? And that was the challenge that we faced as an older adult service.
So how did we respond to that, and what did we do about that, and what did we learn? So I think what we're going to do now is just run through some of the key lessons we learned, and some of the key bits of work that we did, and what we feel we can take away from that. Well, one of the things we learned, first of all, is actually that we could change at pace, that we could make significant operational changes, that when unrestrained and when necessitated by the need that was present. And one of the key things that we did was that we looked at consolidating our wards. We had to improve our staffing ratios to protect our most vulnerable staff, and to do that we reduced the number of inpatient beds we had in order to enhance our staffing on our remaining beds. However, what that did mean was that we needed to reduce admissions into the ward, both because of the reduced beds and also because of the increased risk of infection that is unavoidably present in inpatient settings. So to support that, we quickly moved to 7-day CMHT working with the support of our teams, and also developed a dementia home treatment team to provide enhanced 7-day-a-week support and input to patients with higher level needs for individuals experiencing dementia who otherwise would have been admitted. This was an existing shortfall in service, so it did bring about an equity for older adults in terms of service provision, and also met what we've known for a long time, and that is that healthcare needs don't stop on a Friday. In fact, they are 7 days a week. And whilst we've known this for many, many years and it's been discussed, the current situation afforded us the opportunity and the necessity to move to that. And that means now we can evaluate the outcomes from that. We're proud to say that during this period, we've had no out-of-area admissions as a consequence of reducing beds and providing this service. And also looking forward, it means that we can look to better support the care homes and look at delivering services in a different way, which will obviously be part of the evaluation of our services. So they were 2 key things that we did operationally and in terms of configuration.
Okay. And as part of our divisional response, it made us stand still and actually focus on who and how we're delivering our services, and making sure that we delivered support to our most vulnerable. And it was defining vulnerability in the sense of the pandemic, but also in terms of reduced access to other services and how that impacted on people. It made us look at our pathways and the realisation actually it should be a patient pathway and not a service-led pathway. And I think due to the close collaboration that we had within the division, that enabled us to start doing that. It's also made a real sharp focus on our response to our carers. We closed visiting on our inpatient wards, access in terms that Collins will talk about in terms of information that supports assessment pathways. We had to relook at that, and making sure that we had clear plans, documented plans, have the consultation with carers that we ask carers, how do you want us to consult with you? How do you want us to engage with you? How do you want us to support with you? And that we delivered that, and that we checked that we were delivering that. It made us also, we did several checks during this time to make sure that we're delivering services in a way that patients and carers still understood how they could access and be supported. And use technology, I think, was the key things, and doing things differently, challenging our own assumptions as well within that.
Okay, so COVID-19 obviously made us think a lot about how we would deliver services, and technology was something that we knew was key. And we had to challenge the old way of thinking about how things were run. There were about 5 main areas where we tend to work. One is the clinics, the ward, and the memory assessment services. And also we relied a lot on CT scans and blood tests. So these 5 areas were areas where we had to think about what to do differently. So with our clinics, we had to quickly look at our patients, because most of them would require traveling to these places, to our sites, and with COVID-19 this was not possible anymore. We had to change to telephone assessment and video assessment, and to our surprise our patients embraced these changes. The carers were happy to be called at home, and the assessments continued as normal using technology. This had benefits for our services as well. Travel time was less, and throughput through our services and waiting times were not affected as a result of these changes. With the wards, again, ward rounds have traditionally been things that we've always thought you had to do face to face. But again, we had, as Steve mentioned, we had to consolidate our patients onto one site. There was a high degree of pathology in older people during the COVID crisis, high levels of anxiety, high levels of psychotic illnesses, depression was very high, and we had our wards full of very unwell people. And that meant that patients had to be reviewed. But again, technology made this work. So ward rounds were done through video. We were able to RAG rate our patients so that those who were red or those who were classified as high risk were those that we were able to see face to face. And those who were classified as less risky patients were able to be assessed or reviewed through video or telephone. But we also gave patients the choice that if they wanted to see a consultant or a doctor, that option was still there. So it was about offering a personalized approach to our patients, and sort of like, instead of having one size fits all, we were able to tailor our services or our offer to the needs of the patient. The patient was central. Memory clinics, again, is another part of our service where we traditionally do them by either driving to the patient's home or asking them to come to our services. Again, we had to look at our pathways. We changed that very early on and modified them to virtual memory clinics. So patients were assessed over the phone, and questionnaires were completed by our staff, and we were able to, again, if needed, bring patients in for only specific parts of the pathway. And we relied less on tests, and technology allowed us to assess patients and access all the investigations that we would often ask patients to repeat. We had access to the care portal that allowed us to look at blood tests, CT scans, and that meant we didn't have to order these tests again. The benefits again was that waits were cut down and patients were seen on time. Neuroimaging is one part of our pathway that we tend to do quite a bit. CT scans and x-rays and things that we tend to do on older people. And I don't know if it's what we found out was that the acute hospital were no longer offering routine CT scans. that meant that for patients who were going to have investigations, a lot of these things had stopped. So we had to think and adapt our processes, and we relied a lot on clinical assessments. We standardized our pathways. We offered training to our staff, which meant they became more confident in taking histories, and we were able to continue offering diagnostic assessments for our patients without the need for CT scans. Obviously, where patients needed to have scans, and if it was an urgent CT scans, the offer was still there. And finally, investigations. So we very often ask GPs to do blood tests, and in these instances, many patients were not able to go out. They were scared, and they were all at home. Through the home treatment teams, we were able to offer assessments at home. We did blood tests, ECGs, and offered investigations for our patients at home. And this allowed assessments to continue without any impact on quality. So if I have to conclude here, what this has taught me or taught us here is that technology and old ways of working have been challenged by COVID-19. We've been able to deliver services without any impact on quality or waiting times throughout the crisis. We were surprised to hear that in some parts of the country, memory assessment services ceased to operate, but we continued at pace. And it's clearly something that we intend to continue to do moving forward.
Okay, thank you, Collins. And I suppose one of the challenges there is how we sustain change within what's now called the new normal. And I think it's fair to say that a lot of these changes are in their infancy, but from the last few months in looking at how we can continue to support patients during these incredibly difficult times have offered us insights into opportunities that brought about positive patient choice and provided options that we can develop further to enhance our service capacity and response, and also therefore our patient experience. However, I think it's fair to say that we now need to evaluate those and start to look at any risks that have been introduced and respond to those as well. But it has allowed us to challenge, as Colin said, old paradigms and traditions, old assumptions that we ourselves held about how things had to be done. And I think that's been the biggest change, and that has generated some interest in the way that we're thinking regionally, for us to start sharing those ideas, because we are thinking differently about how we do things. So where does that take us? Well, I think very quickly to summarise what it's shown us is that necessity truly is the mother of invention, that when things need to happen, they can, and that the system and the services can respond and adapt efficiently, effectively when required, and certainly when they're less restrained. However, as I said, that comes with the proviso that we have to have that hindsight and look at the risks to introduce, but that we can change at pace, I think is incredibly important, because it means that we can evaluate whether things are effective or not far more quickly. But as especially I think Collins and Dawn have both highlighted, what it's really brought to the forefront, if it needed to ever be brought to the forefront, even more than it was, that this is about patient experience, about how they interface with our services, about how we do things, and that they have to be at the centre of everything we do, pandemic or no pandemic. So that's it for us. It was a very quick talk through, but happy to take any questions anybody has.
Thanks so much, Steve, Dawn and Collins. And Collins has actually been able to join us live as well if there are any questions. Really good to hear that transformation, another interpretation of the new normal, which was really important to hear, and also really good to hear about the work with carers as well. And all three of those services have really demonstrated that incredible innovation and flexibility through the pandemic that has been absolutely patient focused. So I'll ask Karen whether or not we have had any questions come through yet. Karen?
No questions, Paul.
Okay, in which case, what I'm going to suggest is that we just take a few minutes break, a comfort break for us all, before we hear the last presentation. So if we could reconvene at 3:50, so 10 to 4, and we will hear about our specialist services, and then I will say some closing comments as well. So let's reconvene at 10 to. Thank you. Okay, everybody, welcome back, and we have got one more presentation to work through, which is a presentation from our specialist services, and that presentation is going to come from Rob Harvey and Dr. Daisy Bradshaw, and both are also available for questions and answers after this presentation. So if we could roll video again, please.
Hi everyone, my name is Rob Harvey. I am the Associate Director of Operations for Specialist Services.
Hello everyone, I'm Daisy Bradshaw. I'm Consultant Psychiatrist and Clinical Director for Specialist Services.
So just to really quickly explain what's in the division. So for children and young people, we provide a number of services, both emotional wellbeing and mental health. And that's both in schools, in community settings, in hospitals, and in the child's usual place of residence. So we work both with children and with their families as well. We also provide mental health and physical health team for children and young people in the Lincolnshire Secure Service too. For adults, we provide the learning disability services, the specialist services for Lincolnshire. So the local authority provide the community nursing service and we provide the specialist services. And for adults who may be autistic, we also provide the autism diagnostic service too, so that's to find out whether or not someone does or does not have autism. For liaison services, we provide services into both GP surgeries and the acute hospitals, so whether that's Lincoln Hospital, Grantham Hospital or Boston Hospital, for people with learning disabilities and autism or autism. And we also provide a liaison service to our own mental health services in the other divisions for people with mental health problem who also have a learning disability and or autism as well. We've got some other specialist services, so these operate for the whole county, and they are our adult eating disorder service, for which we also have a day programme. We provide the dietetic service, so that's a dietitian if you need one, or anyone open to any of Lincolnshire Partnerships services. And we also provide the sexual assault referral centre. We have around 450 staff in the division. We work over all the age ranges, from very young children to older adults as well. And we operate over the whole of the county of Lincolnshire, but also in North East Lincolnshire, where we run some services for children and young people in relation to their emotional health, wellbeing and mental health. Just to recap what happened in 2019-2020, so last year. In October time, we had to take the decision to temporarily close what is called Ash Villa. Ash Villa is a inpatient psychiatric hospital for children and young people. And when we closed that, we moved all of the staff from Ash Villa into the community to create the intensive home treatment service. And we did that with the aim of trying to avoid hospital admissions for children and young people around their mental health, or if they did need an admission, to make sure that it was for a short amount of time as possible. And that's part of the new care model for children and young people, which we'll talk about a bit later on. We also started to set up our Lincoln and Gainsborough mental health support team. So that's part of a national pilot, and that's specifically aimed at putting mental health staff into schools to make sure that we're supporting both teachers and education professionals, but also children and young people and their families, particularly in relation to anxiety and depression. Our children's services won a national award, so one of our services called Healthy Minds in Lincolnshire won the Mental Health Now Awards, and we've been shortlisted for other awards. We started the service I mentioned earlier, the dietetic service, and the Sexual Assault Referral Centre also achieved Lion Culture accreditation as well. This year, whilst there has been other stuff going on, a really significant thing we've had to deal with, as have all NHS organisations, has been COVID-19. So we have had to pause certain things. So one of the things that we paused was routine face-to-face appointments. As part of that, that meant that our autism diagnostics service for adults was closed in Lincolnshire, and autism diagnostics for children in North East Lincolnshire was also closed, as was our ADHD assessments as well up in North East Lincolnshire. Our eating disorder day hospital closed, and so did our crisis drop-in for children and young people. And we also have a number of meetings where we meet as staff face-to-face or as teams face-to-face. And we paused that as well. And as part of that, we asked our staff to stop coming into our offices as much, and that meant that we would only be using the office space for the people that desperately needed to be in the office and for emergency and urgent clinical work too. And also, as care homes and residential homes went into lockdown, we had to pause doing appointments in those kind of type of environments too, whether that was for children or adults with a learning disability or autism. To balance that, we still had to make sure that our services were still safe and accessible for the people of Lincolnshire. So we continue to see high risk service users and people who were deemed an emergency, and we continue to do that face to face. We developed a number of tools to make sure that we were prioritising the most vulnerable people and those identified as high risk. And the reason we developed the tools was to make sure that we were being as consistent as possible throughout the county, but also because we have a lot of different services in the division too, so we needed to make sure that they were adapted for that. We made sure that we continue to make regular contact with the most vulnerable patients that we have in the division, and the routine referrals then moved onto phone and video. So whilst I said we paused them earlier, we paused them face to face, but we continue to do stuff wherever we could by phone and video. We used our experts by experience and peer support workers to make sure that we developed a lot of self-help material, and we did that in a way that was as easily accessible to anyone with a mental health problem, learning disability or autism. And we'll talk a bit more about that later on. And we also made sure that specifically in relation to COVID that we trained our staff in some of the additional physical health skills that they might need. So for children and young people, to make sure that our services were still safe and accessible, in North East Lincolnshire we work with our partners, so the local authority who provide social services, the voluntary and community sector organisations throughout North East Lincolnshire, and the provider of adult mental health services up there, to make sure that we had an all-age 24/7 crisis referral and advice line that was available to everyone who wanted to call. In Lincolnshire, we developed the Here For You line as well. So our Here For You line is a line that's available for professionals to call and get advice around children and young people's mental health and to make referrals. But we opened that to everyone to make sure that anyone could refer in. And we started to make sure that, because we have a number of different services within Lincolnshire for children and young people, we started to make sure that our referral processes were shared between those teams to make sure that we weren't bouncing people around between services. We have now started a 24/7 advice and crisis line, very similar to the one with North East Lincolnshire, and we're doing that with the support from our partners in the adult acute division. And we have made sure that we've co-located services wherever possible as well, to make sure that we have the required number of staff in a building at any one time. Also for children and young people, I mentioned earlier about the way in which we've developed some self-help resources. So we've developed training videos, we've developed a lot of advice for people who may be suffering around their kind of mental health, and we put that all onto the Lincolnshire Partnership Foundation Trust website, and on there we previously, prior to COVID, we saw around 200 hits on that page a month, and for August we averaged around 10,000. So we're starting to see a lot of demand for people being able to access self-help material. For the Lincolnshire Secure unit as well, we had a young person test COVID positive in there relatively early on. So we needed to make sure that we locked down that building as much as possible. It's already a locked unit, but we needed to make sure that we particularly made sure that COVID didn't get through the people that are staying there at the minute. And so we work very closely with our local authority colleagues to make sure that we reduce the psychological impact of anyone who needed to isolate. For all of our services, we made sure that we advertised those through social media in schools, because whilst we had to pause some very specific things, and whilst we changed routine work from face-to-face to digital and telephone, we were still open, and we wanted to make sure that anyone that needed our services knew how to access them. For people with learning disabilities, we put all of our key documents into easy read to make sure that everyone understood how to access the services if they needed to. But a lot of our services for people with a learning disability are accessed through carers, and we support a lot of carers too. So we made sure we continue to do that digitally, and that we develop booklets to support carers too. And around physical health, in case anyone needed to go into any of the acute hospitals in Lincolnshire, we made sure that people had a health passport. And that's to make sure that when people go into hospital, that the staff in that hospital understand the adjustments that that person might need and how they communicate. For autistic people, again, we made sure that health passports were in place as well. So some autistic people may find that communication is a particular issue for them. So again, trying to communicate what reasonable adjustments needed to be made was very important. But we also made sure that for the Autism Diagnostics Service, which paused, that we kept the contact details of everyone who had been referred in to make sure that for both GPs, they weren't having to re-refer, but also for the service user who had been referred in, that we would then just contact them as soon as the service could be reopened, rather than making people go through lots of different processes to come back in. And in relation to supporting our staff, we've done lots of risk assessments, either on specific groups of staff or for people in specific situations. And we've also asked people to not come into the offices as much, and as part of that, we've really tried to adapt how we work to make sure that people can work from home. We've had a real focus on supervision, so whether that's around making sure that people understand how the services are working in COVID world, and also that because we've changed the way in which we do some of the work, and that's been a long established way of working, that we want to make sure that our clinical supervision's been really up to scratch as well. So we've been doing that. And we've been really encouraging people to try and meet up as virtual teams. So even though lots of our teams now haven't been in the same building for a number of months, we've been trying to make sure that people have a virtual cuppa or a virtual lunch or whatever it might be, just to make sure that they maintain that sense as part of a team. And I'm now going to hand over to Daisy to talk about what we're planning to do moving forward.
Thank you, Rob. Moving forward, I think we recognize that COVID was a rapidly changing situation for us, and now coming out of it, we're looking at to gather all the available data, and we'll do this by speaking to our service users, our carers, their families, and the staff to look at how they have experienced accessing our service during the COVID, and to also find out what worked well and what didn't, and what we can change depending on what we extract from those data we have gathered. In addition, as we open our buildings, our estate colleagues in estates, they've supported us in risk assessing the buildings. So they have looked at issues around how many people you can have in clinic rooms. They've looked at infection control and also clearly marking the buildings. Also, we are mindful that we might have a potential increases in referrals. So we have looked at how we manage this should we come to that point, particularly for children and young people. And how we have done this is to look at our caseloads and prioritize those in high risk and those in medium and mild, and put staffs around and increase our staff presence to be able to respond to those increased referrals. And this is more important as children go back to school. we're expecting the referrals to increase, and also as care homes and residential settings open up again to visitors. And we are using the range of online and range of leaflets and online trainings we have developed to support staff in those settings to be able to meet the expected demands, presentations with people with mental health difficulties. Likewise, those with complex eating disorders, staff are trained and they're having a lot of online videos and online e-learnings for staff to use, as well as carers. And we have telephone helplines for carers and families to contact us and seek advice from. We continue to make sure that we offer the digital platforms we have trialed during the COVID period, and these include video conferencing facilities or telephone. And we know from speaking to our service users and their families, they have found this useful. So for us now is to find out a balance between patient safety as well as patient's preference on being seen and having their needs met. And as well, we'll support our professionals and service users. This is particularly important for people in our learning disability services, who mostly will communicate via their carers or their families or the professionals supporting them. And with the help and support of the guided self-help and the online training materials, we hope and we are confident that this will meet their needs. And again, we'll continue to adapt and change things as we gather evidence and feedbacks from people using those services. Our eating disorder day hospital has reopened, and this was supported by lots of preparations before reopening, and this included looking at how to meet the new government guidelines around infection control and limiting the spread of infection. They have done things around adapting the number of people they can have in the building, adapting how service users can attend, as well as how they manage the programs within the hospital. And early feedback suggests that both staff and the patients using these two services have found it useful. And I think this is important given that during lockdown, most of these patients did not have access to the day hospital because it was paused. We will continue with the 24-hour, 7 days a week advice and guidance line that was recently started for children and young people. And this, again, we feel is quite important as we return to the new normal and children have resumed their daily life, both in school and at home and with their communities. Services like those ones serving the children and young people are now co-located in the same place. And this also goes a long way to make sure that we are maximizing the use of our buildings, as well as ensuring that colleagues can benefit from having each other to interact with, and also to have the catch-ups with. And also the integration of services we spoke about following the closure of Ash Villa and the re-emergence of the complex and crisis community service, which has been recently evaluated and found to be satisfactory to those using the services. Our autism diagnostic services, which we paused during the COVID, we are reopening it, and we are looking at different ways to collect the information we need for those services. For the diagnostic service, we're looking at doing things slightly like using the online platform to take the histories and to speak to professionals, and then looking at other ways to do the face-to-face. Some of the changes we have spoken about and discussed include use of clear view face masks to make it possible to have a face-to-face assessment. And I think it's important to reiterate again that for the ones referred during the COVID, we have their details and we'll be making contact with them to improve that ease of access to the services. The mental health support teams, which are there to support schools, professionals within schools, they continue to expand, and we're looking at going further afield. So in addition to the Lincoln and the Gainsborough, we're looking at expanding to the East Coast, which is the Louth, Skegness area. And we know from the data we have gathered that this is what that students, professionals and teachers, they have found it useful. And I think it's something we're hoping to take forward as we move into the new normal. New care models. This was conversation we started prior to COVID, and we paused during COVID, and we're coming back to it. It is a different way of meeting people's needs. And our children and young people service, the CAMS and eating disorder team, they have the new care models coming. We have the CAMS service, they have evaluated the complex and crisis team and found that it's a very useful way of preventing children being admitted to hospitals, and also should you then need to be admitted and people are discharged quicker than usual back into the community. And also people are supported within their own family units, preventing that disintegration of family links. So in all, new care model, it is something that is innovative, it's a different way of working, is providing care nearer to people's home, and which we have found patients, families and carers prefer, and they have found it useful. Moving forward, we are going to do our very best to continue to meet our children and young people in our learning disability services, as well as eating disorder service users, to meet their needs, and we'll continue speaking to them and ensure we adapt our service to reflect what the information we gather back from them as we move into the new normal.
Thanks ever so much for that presentation, Rob and Daisy. And again, I'll go to Karen to ask if we've got any questions, please. Karen.
Yes, Paul, we have two questions from Ed Garcia. The first of which is, the size of Lincolnshire is considerable. How do you deal with the logistical issues and challenges, especially now in the new reality of COVID-19? The second question, rather than dislocated services, is there a plan to develop or evolve into one-stop integrated services?
Great questions, really reflecting one of the challenges for us as a county-wide organisation. So can I hand across to Rob and Daisy, and just to say to everybody, they are definitely socially distanced. Sometimes it doesn't look like that on screen, but they absolutely are. So Rob and Daisy, please.
Hi everyone. I think in relation to the first question about covering the county during COVID, I think we've spoken quite a lot about digital interventions during that presentation, and I definitely think that that's something we want to continue to build on. We know that it's not the answer to every problem, but it is a way of us being able to make sure that we aren't travelling throughout the county as potential spreaders of infection ourselves, but also then that we aren't asking lots of people to either congregate in our buildings or in big public spaces, so that we can then see them there. So I think it does gives us an additional option that perhaps we weren't utilising as well as we could have been before COVID. At the same time, I think there are definitely a group of people who will continue to need to have face-to-face involvement, and that will just rely on us limiting who that goes to, and that'll have to be a clinical decision that's made based on a combination of need and urgency. I also think that there is something about how we manage to get in. So one of the things we're doing at the minute is we're trying to get into school assemblies, for example, so that we can speak to large numbers of professionals and large numbers of students in our children and young people services, but from a very socially distanced place, and so that we can talk to people en masse, and then we can start to try and understand how we can direct people towards the services that are going to be most appropriate for them. And in relation to the question about integrating services, I can talk about that more from a children and young people's perspective. Ourselves in LPFT and the commissioners share an ambition to, at the minute what we have is we have 4 different contracts across our children and young people services, and we want to try and bring those into one place. And what that will allow us to do is to be able to start to work more in a way that puts the child and the family at the centre of what we're trying to do, which is definitely what we do now, but it will actually mean that we can then start to think about what are the needs of people presenting with and how we can respond to that. So I think it will put us in a different place from where we've been historically commissioned, which has been predominantly around you know, people with a moderate need get X service, usually core CAMS, for example. And I think this will allow us to work more flexibly so that we can follow people through the pathways and start to have a continuity of care that historically perhaps hasn't been there.
That's great. Thanks ever so much for that response, Rob. Daisy, I don't know if there's anything you wanted to add in response to either of those questions, or whether Rob's covered off everything.
I think Rob's covered most of it, but just to add that the rest of the services that make up the specialist division, they are county-wide, though they operate on a spoke and hub model. So they might have their main base in Lincoln, but we have outreach clinics scattered around the county, and we go out as often as we can. And with the arrival of the digital platform, that's going to make it easier. And with clinical decisions, you can see people that require face-to-face from a site near to them, as well as be able to operate from base, limiting the number of hours we spend on the road, freeing up time to see more people during the working hours. So in all, we're moving towards a positive direction with what we've got at the moment.
That's great. Thank you very much for both the presentation and also for responding to those questions. So we're just drawing towards the close for today's annual public meeting, and there's just a few reflections that I'd like to give. First of all, it's been an absolute delight to listen to colleagues reflecting on this year, and I was really struck by, whilst there was lots of reference to COVID-19, and that's absolutely right and reflects the massive challenges we've had, we've heard about so much more, and it's been a real delight to hear from all of those services, and also from our executive colleagues who were presenting earlier, about that breadth of work that has been achieved under the banner of Lincolnshire Partnership. So I'd like to thank everybody who's taken the time to present, both on video and to be with us in person. A few other thank yous. I'd like to give a big thank you to Joe, Amy and Karen, who have been safely distanced in a room with me, managing all of the technology pieces behind the scenes and doing our best to make sure that we're connecting with those who are asking questions, etc. Really great work for the first time that we've been doing such an event like this through digital means. I'd also like to specifically thank our executive team for your leadership throughout this year. It does feel sometimes like it's kind of been a year of 2 parts, that pre-COVID and post-COVID, but I've been really proud of the way that you've led the organisation throughout the whole year, so thank you. And I'd also like to thank my non-executive director colleagues who have been very quiet but on the call for the whole of this meeting, and I know they share my pride and joy in what a fantastic year it's been for the Trust. And I'd also like to thank our lead governor, Pauline Mountain, and also all of our governors, including those who served in the earlier part of the year but are no longer on the council. You're a really important part of ensuring that we do well as an organisation. And I thank you for your volunteering and for your contribution to the Trust. And as was said a bit earlier on, this is my 6th and final annual public meeting. Those 6 years feel like they've absolutely flown by, and it's been an absolute privilege to be chair of such a dynamic and wonderful trust. I think I'm particularly passionate about values and the way we interact together, and one of the things I'm most proud of is the way that as a trust our staff engage to develop our values that we then all work to strive to live to. And I strive to live the values of the Trust throughout my years here. And I very much hope and expect that those values will continue to thrive in the organisation in the future. And I remember right at the start of joining LPFT, I'd got an ambition that we would become a provider of outstanding services, but also would become an outstanding employer. And I hope that we've managed to make a lot of progress over those years. So I will miss you all when I finally leave, but I am here for a few more months. So don't say goodbye yet, and I will keep on working really hard on behalf of the Trust. So I'll draw the annual public meeting and the annual members meeting and our update from services to a close, and just say that I look forward to joining you as an audience member next year. Thanks very much, everybody. Goodbye.